I call this meeting to order. Welcome to meeting number 15 of the House of Commons Standing Committee on Health. Today we're going to meet for 2 hours to hear from witnesses on our study of Canada's health workforce. Before I introduce today's witnesses, a few regular reminders for hybrid meetings. Today's meeting is taking place in hybrid format pursuant to the House Order of November 25th, 2021, per the directive of the Board of Internal Economy of March 10th, 2022. All those attending the meeting in person must wear a mask except members who are at their place during proceedings. A few comments just for the benefit of witnesses and members. Please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your mic. Please mute yourself when you are not speaking. Interpretation for those on Zoom, you have the choice at the bottom of your screen of either Floor, English, or French. For those in the room, you can use the earpiece to select the desired channel. Please don't take any screenshots or photos. That isn't permitted. The proceedings today will be made available via the House of Commons website. And in accordance with our routine motion, I'm informing the committee that all witnesses have completed the required connection tests in advance of the meeting. We are very pleased to welcome our witnesses here today, and thank you for your patience while we fulfilled our democratic duty, but that did cause a bit of a delay in our meeting, so thanks for sticking with us. We'll still have the full 2 hours with you. We have with us today as an individual Dr. Hugh McGuire, the head of psychiatry, Nova Scotia Northern Zone, and assistant professor at Dalhousie University. Représentant l'Association des chirurgiens.
From the Association des chirurgiens cardiovasculaires et thoraciques du Québec, Dr. Louis Perrault.
From the Canadian Pharmacists Association, Dr. Danielle Pace, a Chief Pharmacist Officer. From the College of Family Physicians of Canada, Dr. Brady Bouchard, President, Dr. Francine Lemire, Executive Director and Chief Executive Officer. From the Royal College of Physicians and Surgeons of Canada, Dr. Ghislaine Lefebvre, Executive Director, Membership Engagement and Programs, and from the Speech Language and Audiology Canada, Dawn Wilson, Chief Executive Officer, and Susan Ravachu, full professor. Thank you all for taking the time to appear today. We're going to begin with opening remarks in the order that that our guests appear on the notice of meeting. So we're going to start with Dr. McGuire for your opening remarks. You have 5 minutes, Dr. McGuire. Welcome to the committee. You have the floor.
Thanks very much for inviting me to speak today. I was nervous enough, and then I saw speech, language, and audiology in the room. I need to speak as clearly as I can. First of all, I just want to say I'm grateful to be presenting here today and to contribute to this very important work as we look at Canada's healthcare resources. It's never been so clear that healthcare is important as maybe the last 2 years as we dealt with a worldwide pandemic. In Nova Scotia, we did our best to deal with the pandemic, and we actually saw an upsurge in our use of telehealth. So we were able to use Zoom technology to see patients in rural and remote areas. We're fortunate in that psychiatry and mental health are particularly well suited to this technology, and it did help us see patients in remote areas on an urgent basis who would not otherwise have been seen. This brought to light the need for improved access to broadband internet in rural areas, and if the federal government was to support that, that would be helpful. Also, if we were to support rural hospitals and communities have improved technology to access those services, that would be very helpful. Even though telehealth is a burgeoning field, it's not the same as in-person sessions. And so we still need boots on the ground. And today I would like to mention the importance of recruitment and retention of healthcare workers to Canada, especially rural areas. My experiences with physicians, but I believe my comments would apply to other healthcare workers as well. Essentially, we're trying to get doctors to come to a rural area and then stay and then be happy they stayed. Part of the process of getting doctors to come to rural areas is number one, training doctors at home, and we're doing good work in our med schools across the country to try and find doctors well suited to rural practice and help them tailor their studies to best allow them to do that. We also bring in doctors from overseas, and I wish to speak today to the importance of streamlined immigration. So we have had a number of doctors agree to come to rural Nova Scotia whose arrival here was delayed considerably by challenges with the immigration process. And one of the things that came up during the pandemic especially was that we had an inability to effectively communicate with immigration and to troubleshoot some of these problems, resulting in one physician actually arriving in Canada 3 weeks before his family, who had to pay for a hotel in London, England for 3 weeks, waiting for things to get sorted out. So if we were able to have a streamlined process for immigration and then improved communication between the Federal Department of Immigration and our provincial health authorities, that would be helpful. The federal government has been doing work to promote national licensure for physicians. This is also helpful with portability and helping rural areas reach out to locums when in need. Aligned with that would be a federal locum program where we can again access help for doctors in rural areas. There are doctors who are challenged by the idea of coming to a rural area because they're frankly afraid they won't be able to leave, they won't be able to get a break. So a federal locum program would assist those doctors in knowing they would actually get the time off when they so much need it. When a doctor comes to a rural area, we need to do everything we can to support them in their careers, which means giving them fulfilling work, offering them the opportunity to have a good work-life balance, as well as the opportunity to continue to have their continuing education, whether it be by Zoom in their local clinics or actually get away to attend a conference. Support we can give in this area would also be quite helpful. One of the things that would be helpful is also recognizing the importance of having healthcare workers who decide to come to a community and stay for the long term. So coming up with incentives for longer term service, I think, is very important. One idea that I've pitched locally is the idea of a bursary, a 5-year bursary bonus, where any doctor or healthcare worker who comes to a rural area and stays 5 years after buying a house in the community, they would get a bursary paid out gradually over the following 5 years to encourage them to stay a longer time. Finally, I'd like to speak to the importance of fostering nationwide positive workplace cultures. If we can create positive, healthy workplaces that are culturally safe, welcoming, and inclusive, that would be one of the best ways to encourage our healthcare workers to choose to live in rural areas and also stay. I know that I'm on a timeline here. I know the committee's time is precious, so I'll conclude my comments there, and thank you for your time.
Thank you very much, Dr. McGuire. You'll no doubt have a chance to expand on your comments once we start asking questions. Suite en tant que président.
As the president of the Association des chirurgiens cardiovasculaires et thoraciques du Québec, Dr. Louis Perrault, you have the floor.
Me this afternoon to speak on a very important subject for the healthcare system in Canada. As mentioned before, I'm president of the Quebec Association of Cardiac Surgeons. I'm professor of surgery at the University of Montreal. Been a cardiac surgeon for 25 years, so I've been exposed pretty much to the system day in, day out. One of the things I wanted to speak to, and my colleague, Dr. McGuire, rose a lot of very important points, is the fact that our system showed during COVID that it was not on the brink of disaster, but already collapsed. COVID simply made things evident, not only in Quebec, but all over Canada. And this, in my opinion, is related to chronic underfunding of the health system in Canada. We saw that we didn't have enough beds, not enough personnel, and the lessons that we should have learned from the SARS crisis and the Campbell report way back were not either learned or remembered, because all of the necessary tools were included in that very extensive report that I encourage you to read. I think that sadly, a lot of decisions that were made in health-wise were with a short-term vision, and we do need to look back at the way we entice people to become health professionals, doctors, etc. And it's all well and good to say we will have immigration, but I think that we should have a long-term plan to entice, train, and have the sufficient number of healthcare professional, and that's all across the board. I don't think physicians are part of it, but definitely they're part of a team. And if there's a deficiency in one of the team members in terms of volume, or we cannot function properly. I think that to have a proper culture, as Dr. McGuire said, you need to have sufficient team sizes. And if you don't have a sufficient size, then people will not stay, they will not come. So it's all interrelated, the culture and the workplace environment, et cetera, et cetera. So that is very important. I think that for some reason, the short-term vision should be put aside, that there should be some kind of an independent body that would make decisions to look a generation ahead, 20 years ahead, and make sure that we have a health resource plan so that and also in terms of infrastructure, to be able to take care of the needs of Canadians. We all know that the population is aging, and this is associated with a lot of healthcare needs. The bed levels in Canada are amongst the lowest in these, I would say, Occidental part of the world. Beds are not necessarily always the solution, but definitely they could have been part of the solution during a pandemic. And this should be looked at, because there is going to be another pandemic down the road, the same way COVID followed SARS. And I think it's important to have a body that will be accountable. Some that don't look just 4 years ahead, and that make sure that we will have bang for our buck as Canadians and taxpayers. So again, I thank you. I look forward to answering questions. And I think that this is a time where we need to look way ahead. We cannot put aside or on hold investment for the healthcare system because of COVID. The number of patients that we'll have to treat because they've been undertreated during the COVID pandemic is going to be enormous, and the funding should start now, or else we'll never get over it. I thank you for your attention.
Thank you, Dr. Perreault. Next, on behalf of the College of Family Physicians of Canada, Dr. Brady Bouchard and Dr. Francine Lemire. Who's going to lead off?
I will be leading off.
Okay. Dr. Lemire, please go ahead.
So thank you for inviting us to speak on behalf of the College of Family Physicians of Canada and our more than 42,000 members. I'll be presenting in English and will be pleased to respond to questions in both official languages. My name is Francine Lemire. I'm a family physician and I'm Executive Director and CEO of the CFPC. And I am joined today by our president, Dr. Brady Bouchard, a family physician practicing in North Battleford, Saskatchewan. Thriving health workforce is critical in ensuring Canadians have timely and convenient access to primary care. We'd like to describe the changes that are necessary to ensure that our health workforce can meet the evolving needs of Canadian communities. 4.6 million people in Canada do not have a regular family physician, and many cannot access the care they need when they need it. COVID-19 has accentuated and exposed existing gaps in care, particularly for vulnerable populations such as senior, Indigenous populations, and those suffering from addictions and mental health issues. Providing care during the pandemic has been challenging. Family doctors quickly pivoted to using virtual care while providing excellent in-person care when required. The unique foundational value of family physicians is in providing comprehensive care to patients and families across the ages, including preventative care over time in a variety of settings. The evidence is solid. Countries with robust primary care featuring family doctor leadership have better population outcomes. However, in COVID's wake, we're concerned about reports of family physicians and other providers feeling burnt out, retiring early, significantly reducing their clinical commitments, or leaving the profession altogether. Every Canadian should have access to quality care close to home in family practice. Better access is possible if family doctors and their teams spend less time on the things that are in direct patient care, such as general paperwork and clinic administration. If more family doctors are available, Canada consistently lags behind other OECD countries in physician numbers. And if family doctors working in teams are more available to their patients, and a wider array of services are available through the team. Addressing each of those areas will retain the workforce, maintain well-being, and ultimately improve access. What can we do? The government's commitment to increase the family physician supply is commendable, but doing so will take time. In short term, we must ease the burden on the frontline family physicians by first establishing a time-limited fund to incentivize retention of family physicians and other primary healthcare providers who are considering leaving the workforce post-pandemic or are already on their way out. Second, provide administrative support to primary healthcare teams through dedicated funding and streamlined administrative processes, creating more time and capacity for direct patient care. A recent survey of our members ranked administrative support as the top requirement to enhance access. Looking further ahead, we need to consider several systemic issues to make our workforce supply and distribution more resilient, equitable, and adaptable. We welcome a recent announcement to increase family medicine capacity in some medical schools. There must be consistent, deliberate action to increase supply and to enhance capacity with a focus on underserviced settings and populations. Now, more than ever, we need a robust provincial and national data strategy. Numbers are not enough. We must understand and take into account what providers do, their scope of practice, and their career trajectories. We must sustain and expand practice environments that are good for patients and providers. The CFPC promotes the concept of the patient medical home, a vision of care that is collaborative, team-based, patient-centered, and strongly connected to the community and healthcare system as a whole. Further progress on expanding this type of care must be supported through a dedicated primary care transition fund that we've been advocating for in partnership with the Canadian Medical Association and the Canadian Nurses Association. There's a general sense of lack of appreciation and support among family physicians who are feeling burnt out and overburdened. Our members continue to serve as a foundation of Canada's healthcare system and trusted partners to their patients. It is critical that family doctors and other health professionals get the support they need, both in acknowledging their contributions and through the dedicated support from all levels of government. Thank you.
Dr. Lemire. Next, on behalf of the Canadian Pharmacists Association, Dr. Danielle Pace. Welcome to the committee, Dr. Pace. You have the floor.
Thank you. Good afternoon, and thank you for the opportunity to be part of this important and timely study. My name is Danielle Pace. I am the Chief Pharmacist Officer for the Canadian Pharmacists Association. Today, I am joining you from the traditional and unceded territory of the Three Fires Confederacy of First Nations, the Odawa, Ojibwe, and the Potawatomi. CPHA represents Canada's 47,000 pharmacists who, along with their teams of pharmacy technicians and assistants, have worked tirelessly throughout the pandemic to support us all. I want to spend a few moments highlighting the role of pharmacists during the pandemic. When the pandemic started, pharmacies were one of the only community healthcare providers to remain open to the public when most others closed or transitioned to virtual care. They did so amidst great uncertainty, not knowing how to protect themselves or their staff, while also trying to manage drug shortages and disruptions. The pandemic has truly highlighted the essential role that pharmacists and pharmacies play in healthcare. Pharmacists have been an important source of COVID-19 information for the public and have had to navigate a consistently changing environment and in some cases with little or no advance notice. In many parts of the country, pharmacists distribute and administer COVID-19 tests, and they are a leading provider of COVID-19 vaccines with over 17 million administered in pharmacies to date. And although COVID has dominated the last 2 years, the opioid crisis hasn't gone away. Through an exemption provided by the federal government during the pandemic, pharmacists were able to extend care to patients using opioids and other controlled substances. This was especially important because they helped those individuals struggling with addiction maintain their treatment. The pandemic, however, has come with a toll due to the relentless demands placed on all healthcare workers within a system that was already stretched. Over the past few weeks, you've heard many common themes from witnesses who have appeared. Our own experience, supported by a national survey we recently conducted, reinforces that mental health of our pharmacy workforce has been significantly impacted by burnout, labor shortages, and patient harassment. It saddens me to share that during the pandemic, almost half of respondents have experienced abuse or harassment from patients at least once a week, and some even daily. Like our physician and nursing colleagues, the pandemic has had a major impact on the supply of pharmacists and their support staff. We're seeing an alarmingly high number contemplate leaving the profession. It's been heartbreaking to listen to the stories of my frontline colleagues who are exhausted. For most, the stress and pressures they're under at work, coupled with the challenges they face personally, are at a breaking point. We believe urgent action is needed to address this impending catastrophe, and that the federal government can play an important role in providing direct support to health providers, as well as indirect support through the provinces and territories. This includes targeted mental health resources to help pharmacy teams cope with the struggles they faced over the past 2 years, as well as strategies and funding to ensure that we have the appropriate supply of pharmacy professionals, particularly in rural and remote areas. Financial incentives, loan forgiveness for healthcare workers, and subsidies for employers providing practical experience to students and internationally trained healthcare workers are just a few of the recommendations that we believe could help avert a future healthcare workforce shortage and emergency. As the committee considers strategies to improve recruitment and retention of healthcare providers, I would be remiss if I did not talk about the lack of consistency with our scope of practice in Canada. Many committee members here today are able to get a flu shot at their local pharmacy, but there are still some territories that haven't enabled pharmacists to provide this service. Similarly, in some parts of the country, pharmacists can prescribe for common ailments like UTIs and skin rashes, but others cannot. This demonstrates clear inequities to care within our existing system. When it comes to recruiting and retaining pharmacy professionals, the ability for us to work to our full scope, regardless of where we live, is so important to our personal and professional fulfillment. Lack of scope can also disincentivize pharmacists from practicing in rural and remote locations. So while health and scope of practice remains mostly a provincial jurisdiction, we believe the federal government should provide targeted funding to the provinces to further expand scopes of practice for pharmacy professionals so they can deliver better care to patients. I'd like to acknowledge again the incredible work and sacrifices of all healthcare workers over the past 2 years. We owe so much to them. And thank you to the committee for allowing me to share how pharmacists and their teams across Canada have contributed to and been impacted by the pandemic. We look forward to seeing the positive outcomes from your dedicated efforts. Thank you.
Thank you very much, Dr. Pace. Next, the Royal College of Physicians and Surgeons of Canada, represented by Dr. Guylaine Lefebvre. You have the floor.
Merci, Mr. Chair, honorable committee members. I thank you for the opportunity to appear today before this committee to discuss the critically important topic of health workforce recruitment and retention. My name is Guylaine Lefebvre. I'm the Executive Director of the Office of Membership, Engagement and Programs at the Royal College of Physicians and Surgeons of Canada. I join this meeting today from Ottawa on the traditional unceded, unsurrendered territory of the Anishinaabe Algonquin Nation. I've been a specialist physician for 30 years. My specialty is obstetrics gynecology, and I've participated as an educator and a leader at many levels of our healthcare system. The Royal College, its governing council, our president, Dr. Richard Resnick, and our CEO, Dr. Susan Moffat-Bruce, remain committed to physician burnout and wellness issues. I offer regrets from our CEO who cannot join today. Dr. Moffat Bruce is committed to this important work in her capacity as a clinician researcher, as well as her position of CEO at the college. We represent more than 50,000 physicians and surgeons across the country. La raison d'être des soins de santé, ce sont les gens.
Why do we have healthcare? For people. When healthcare workers feel well, when they feel supported, patients and communities throughout the country feel better.
I'm grateful to this committee for your commitment to addressing issues relating to recruitment and retention in the health workforce. And so I'd like to share with you what we've heard and what we know from our fellows, our residents, and their colleagues in the health workforce, and what we're doing to support them. Je suis également reconnaissante envers le gouvernement.
I'm also grateful for the government passing Bill C-3 to protect healthcare workers from bullying, which has been the case in increasing numbers of bullying cases.
50,000 specialist physicians and surgeons across Canada. We're not working alone on this issue. We're working in collaboration with other key stakeholders in healthcare, including the membership of the Canadian Medical Forum with its Physician Resource Planning Working Group, and HEAL, Organizations for Health Action, which represents healthcare workers from over 40 organizations and disciplines. We cannot work independently from a system that relies on a team of healthcare workers, from nurses in the operating room and in recovery, to environmental teams that maintain the hospital rooms and clerical staff that look after the entire patient journey. Our physicians are only one piece of the care puzzle, which should always have the patient at the center of the team. 1 in 2 physicians shows signs of advanced burnout. In late stages of burnout, physicians often lose a sense of professional accomplishment and can contemplate leaving the profession. And that's a red flag for all of us. Tout au long de la pandémie de COVID-19,
throughout the COVID pandemic, healthcare workers have stepped up. They've come out of retirement, delayed it, worked extra hours. All this to keep our families, friends, and neighbors healthy.
Study published by CTV, an internal medicine and COVID-19 unit physician explained that we're going to get to a point where we have skeleton crews everywhere, which is not the way a healthcare system can survive. I would argue that we're not surviving now. We're just barely getting by. The reality is we haven't paid the full price of the COVID pandemic, and that day is coming. L'épuisement professionnel.
Burnout, exhaustion, delayed retirement, and the harassment of healthcare workers will all result in people leaving these professions. It will leave us short of healthcare workers at a time when there's a tremendous backlog of procedures and care to be provided.
The demands on the health workforce will only increase, and we may not have enough people left to provide the care. We must also recognize that those who remain in the healthcare sector are stressed, exhausted, and have experienced moral distress and moral injury. During the pandemic, healthcare professionals have been forced into challenging conditions and have had to make impossible decisions. The pandemic has brought to light many issues that already existed in our healthcare system but have been exacerbated in the last 2 years. This means there weren't so thin that it becomes challenging to offer the type of compassionate care that we all want for ourselves and our families. Health workers who are exhausted and burnt out also don't find the same joy and gratification in seeing their patients do well. As a surgeon, I'm intimately familiar with the hardship of knowing that a patient is suffering and needs surgery, but there's no availability of OR time to proceed. The empathy we carry for the patient's pain, the workload of exploring options for care, challenges of keeping waiting lists, all contribute to the moral distress we see with our physicians. Access to care and waiting lists through COVID have gotten even more difficult to manage, but they've been troublesome for years. In March 2020, Dr. Mamta Gautam, a psychiatrist, offered to hold daily Zoom calls to offer peer support to colleagues across the country. She had approximately 2,000 physicians contact her to join the group. In the first few weeks, between 30 and 50 physicians on average would tune into the Zoom call each day, and that number sometimes reached 80. In addition, according to a recently released survey by the Canadian Medical Association, nearly half of the physicians are presently contemplating reducing their workload. The good news is that together we can affect change. Studies have shown that to reduce the incidence of burnout, improve resilience, and ultimately improve patient outcomes, a health system must identify and prioritize a commitment and dedication of resources to support healthcare professionals. Our colleagues at the Canadian Medical Association have created a physician wellness hub, which is one such resource to support physicians in prioritizing their own health. Data is a resource that governments can use to understand the current composition of its health workforce to move our system forward from the pandemic. There are existing health workforce data sets, but these are typically limited to a single jurisdiction based on self-reporting or for-profit databases that were not designed for health workforce planning. There are also critical data gaps in existing workforce data sets, such as a lack of information relating to equity, diversity, and inclusion. Cultivating a healthcare workforce that is representative of the population in which it serves is critical to ensure the best care for all Canadians.
Dr. Lefebvre, sorry to interrupt. Can I get you to try to wrap up there, please?
Timing's perfect. I'm right there. So, the Royal College represents specialist physicians, but our fellows and residents work in teams. To that end, we offer the following recommendations. Collect and analyze data at a national level, ensuring that we have robust data for all jurisdictions and all professions within the healthcare workforce. And continued sustainable investments in programs, policies, and supports for the entire health workforce. The Government of Canada has stepped up during the pandemic to support healthcare workers. We must recognize that the challenges faced during this pandemic will continue, and let's continue investing in it. I thank you for your time, and I'm happy to answer questions when we get a chance.
Thank you, Dr. Lefebvre. Next, the Speech Language and Audiology Canada. Don Wilson and Dr. Susan Revichu. Who's going to speak first?
Actually, Mr. Chair, I am going to speak first.
Okay, go ahead, Ms. Wilson. You have the floor.
Thank you so much. So, Mr. Chair, members of the Health Committee, I'm joined here by my colleague, Dr. Susan Revichu, and we just want to thank you on behalf of Speech, Language and Audiology Canada for the opportunity to speak to you today about our professions. So our members focus on prevention, assessment, and management of communication, swallowing, hearing and balance disorders across the lifespan. Our members, over 7,000 that we represent, are often assisted by communication health assistants and work in a wide range of settings, including schools, hospitals, early years centers, long-term care facilities, and in private practice. In particular, early intervention from our members set up success for children in critical ages 0 to 6 through detection of hearing loss and therapies for speech and/or language delay. Our services are integral to the care, dignity, and quality of life for people living in long-term care facilities due to the high prevalence of communication, swallowing, hearing, and balance disorders in seniors. These difficulties affect personal and caregiving relationships and are also associated with loss of autonomy, isolation, and caregiver stress. And I know, as we can all attest, the ability of residents and facility staff to effectively communicate is paramount for everyone's health and safety. During the peak of the COVID-19 pandemic, many of our members working in healthcare settings were redeployed to assist with pandemic response, further contributing to burnout. Moreover, our members play an important part of COVID recovery, as many SLPs help patients with speech or swallowing issues post-ventilation. As a result of the pandemic closures, many infants miss their newborn screen test. According to the Ontario Ministry of Health, 2 of every 1,000 babies have hearing loss at birth, and 2 more develop it by age 5. As a result of hearing impairment, children have difficulty with their speech and language, which can lead to academic, behavioral, and emotional issues. Closing schools and daycares impact the language and literacy of children and have added to the burnout and heavy caseload of school-based SLPs. Already, we know that 45% of Indigenous children are missing their literacy benchmarks, and Canada lags behind other developed countries. Currently, the number of SLPs and audiologists within Canada is not meeting the needs of the population, in particular the growing aging population. Although Canada's population totals around 12% of US population, the number of Canadian SLPs is around 3% of the number of US SLPs. This poses an issue because the number of SLPs is too small to provide quality treatment to the large and growing number of people with communication and swallowing problems in Canada. Recently, Northwest Territory Health Minister Julie Green said adults must wait 19 months to see audiology in the Beaufort Delta and 26 months in Yellowknife. There are currently only 2 audiologists in the Northwest Territories. According to Health Sciences Association in BC, early intervention therapies, including SLP therapies, have the longest wait times of any child development center program. Currently, it is not unusual for children never to end up having access to an SLP before entering kindergarten, or to wait months or years before accessing service. This lack of service for preschool-age children is particularly acute for Indigenous children, with devastating consequences for their literacy levels, hearing health, school success, social, emotional health, and their vocational outcomes. As well, according to the Canadian Occupational Projection System, over the period of 2019 to 2028, the number of job openings arising from expansion demand and replacement demand for audiologists and speech-language pathologists are expected to total 3,800, while the number of job seekers is expected to only total 2,800. As with many of our healthcare professions, rural and remote areas across the country face issues with recruitment and retention of workforce. Therefore, we implore the government to recommend and endorse the following initiatives. We must ensure that speech-language pathologists and audiologists are eligible for the Canadian or Canada Student Loan Forgiveness Program, in particular those who set up practice in rural and remote communities. We implore the government to provide funding for provinces that will work with partners to create, implement, and manage innovative short and long-term strategies and programs that support the recruitment and retention of SLPs and audiologists. We would ask that the government provide incentives or support to universities to expand or create SLP or audiology programs, and we must invest in telehealth infrastructure as a means of improving access to SLP and audiology services, particularly in rural and remote communities, including our Indigenous communities. We would also like to mention that we support the recommendations provided to HISA by the Canadian Health Workforce Network, who is doing such important work in this area. We thank you for your time today, and we encourage any questions you may have.
Thank you, Ms. Wilson. And we're going to move right to questions now, beginning with Dr. Ellis for 6 minutes.
Thank you, Mr. Chair. Thank you, Mr. Chair. I want to thank all the witnesses for their statements and being with us today in this exceedingly important study that we're doing, which affects all Canadians and probably most acutely Canadians who live rurally. Yeah, just full disclosure, I have been a family doc for 26 years and recently I'm one of those defectors who have come here to work instead, perhaps for a multitude of reasons, who knows. And as my colleagues here know, my wife is also a pharmacist, and I'll give them a shout out because especially my wife is awesome, but all pharmacists are. Thank you. No answer required. Dr. McGuire, thanks for coming. There's a couple of things specifically that you mentioned, broadband internet and immigration, two things that have affected your abilities to deliver care and also to look at solutions for a very acute problem of lack of psychiatrists. Maybe you could give us a bit of a story around the immigration that you talked a bit about with the family of a psychiatrist being left in a London hotel for 3 weeks.
Yeah, no, thank you for inviting me here today. The doctor in question showed up at the London airport to start his new life in Canada. And when they checked in at Heathrow, was informed that he was allowed to get on the plane, but not his family. And so his wife and teenage daughter with their pet dog had to find a hotel on a moment's notice in London, England. At the time, I was aware of the problem, and we were desperately trying to troubleshoot so the family could actually make it onto the plane and board. But we actually just hit one dead end after another in terms of trying to speak with immigration or speak to somebody who could allow the family to board the plane. The family ended up going to the hotel, as I mentioned, and again we was trying to reach out through appropriate channels, which would have been through healthcare in Nova Scotia through the Department of Health, and then tried to reach out to immigration to try and make sure this family could join their father and husband as quickly as possible. In fact, we just found one delay after the other, and the family was just so frustrated. So they ended up having to spend 3 weeks in that hotel in London before they actually got to come to Canada. Meanwhile, the physician had to do his quarantine period in Canada for the 2 weeks alone, without any access to his family. And of course, when they arrived in Canada, they had to do the 2 week quarantine as well. So it was a pretty tough start to their life in Canada. We're lucky that this is a family of resilience, and they have kind of settled into this country and have made Nova Scotia their new home. But it sure was a rocky start and a fairly emotional one by times. So if we had a way to improve our ability to troubleshoot when those issues arise, that would be incredibly helpful to avoid any future problems like that happening.
And Dr. McGuire, through you, Mr. Chair, do you think it's important, our part of our short-term solution, in especially in rural healthcare and perhaps more importantly in rural psychiatry, that immigration and attracting physicians from abroad is a significant part of that strategy?
I think so. I think that applies to physicians and any kind of skilled workers. If there's a way to streamline the immigration process so that those important workers could be in Canada providing care while they're finished being vetting, for example, I think that would be super helpful. I know we do have one psychiatrist who agreed to come join us in 2020, actually early 2020, and that doctor has still not arrived and has therefore given up on his wish to come to Canada.
And finally, Dr. McGuire, we've got about perhaps a minute and a half or so left. Could you speak to the necessity of creating a welcoming environment for families of physicians coming to Canada as well, please?
Yeah, for sure. I mean, the goal is to get doctors to come and then to get them to stay. So for the family in question, we typically when a doctor arrives, we'll make sure that we'll have connections made for their families, activities planned. So for example, one family who came, the daughter is involved in horseback riding. We arranged for that to happen when she arrived. Also make sure we have lots of professional support in the workplace in terms of introducing the doctor to the new environment, how the system works, engaging them in social activities. So I think providing that welcoming environment is key, in fact.
Or if I might, I know you're a practicing psychiatrist as well, working in the emergency room as well. How essential would it be to have a kind of a pan-Canadian electronic medical record that you could access in the emergency room?
Yeah, that'd be that'd be helpful. That'd be terrific. I think we're a long way away, but if we could start the process of getting there, I think that'd be really helpful.
Thank you, Dr. McGuire.
Thank you, Dr.
Thank
Ellis.
you.
Chair.
Next, Dr. Hanley, please, for 6 minutes.
Thank you very much. I'm just thinking about that dream of a pan-Canadian electronic medical record. Yeah, let's do it. Thank you very much also to all the witnesses. And like my colleague opposite, I have also recently joined the dark side from the medical profession. Both on the record. On that note, I think I'm going to go first to Dr. Lemire, and Dr. Lemire may or may not remember my first ever work experience as a family physician was in fact in Corner Brook, Newfoundland, and my first whitewater canoeing experience was with Dr. Lemire and her family. So good to see you again. But Dr. Lemire, my question is around the team-based approach, and I'm wondering if you could expand on that. I was really interested by your talking about the administrative support that family physicians are asking for. So as part of the team, how does that actually work? Are there some good examples? And who else is on the team, or who are the important players on the team? Thanks.
Thank you, Dr. Hanley. I do remember that canoeing experience quite well, actually. So the team-based model of care is a model that we're trying to promote at the moment, and it is already in place in some provinces. Example, family health teams in Ontario, Groupe de médecine familiale au Québec, PCNs in Alberta. So these are some examples of models of care where there is access to a family physician for every person in the practice, but where the family doctor also has the opportunity to work with other providers. We have pharmacists in this virtual room today, so a pharmacist is an important member of the clinical team. As an example, social worker, nurse practitioners, clinical nurses, dietitian, physiotherapists, and the decision as to which providers we privilege as members of a team depends in part on the population that is served. So generally for these models that I've just described, there is an analysis of who is it that we're serving as a practice. And then based on some demographic information, then there's a decision that's made as to which type of providers might be best suited to support the providers in providing the best care for that patient population. So certainly for myself, I worked for several years in such a model in Toronto when I was in clinical practice, and that was an example of this. So I had a fairly close interaction, for example, with the clinical pharmacist in that team, particularly for the frail elderly patients whom I was looking after, who were on more than 6 medications. So every year, the pharmacist would actually review those patients, and we'd have a conversations in terms of, you know, are all these drugs appropriate? Are we able to trim 1 or 2 of these? Are there some drug interactions that I need to be mindful of? So this would be an example of this. Of course, in that practice, as an example, again, we provided immunizations, and clinical nurses were an important provider to help us with administering immunization, identifying people who were due their immunization who had not had them. So certainly working closely with nurses, very important. We often don't talk about the receptionist. So certainly every practice has a receptionist, and having enhanced roles for the receptionists also help to streamline that care. So, I mean, I could go on, but these would be some examples. In the team I was in, we had a social worker, and the social worker was really quite critical for patients who were dependent on funding from social services in terms of identifying some potential sources of funding and working with those patients on some of these applications and forms to fill out.
Thank you very much. I have, Dr. Lemire, I have 1 minute. I think I'm going to move to take advantage of my time as much as possible. That was great. Thank you so much. To the speech and language expert that spoke, I really appreciate that you highlighted the difficulties of recruitment for northern and rural. Is there any role for rotating, locum service, rotating service, virtual care? I wonder if you could comment on some of the other potential ideas for servicing northern and remote areas.
Susan, I'll let you speak to this.
Okay, thank you for the question, and thank you, Dawn. Certainly there is some room for that. I think we have to consider that there is just a massive shortage of speech-language pathologists in Canada, so the number of speech-language pathologists per capita is half what they have in the United States, for example. So we can have locums and we can have virtual care, but there's just not very many speech pathologists, so that's an issue. But we are using virtual care quite a bit, and one particular way in which we're using it is to send students into northern communities and then supervising those students from the city using Zoom and other technologies like this. So there's an opportunity for that. And the other thing is to have communication disorders assistants in those communities who communicate with speech pathologists who are spread further apart and are thinner on the ground.
Thank you, Dr. Revachou. And Dr. Hanley, suite Monsieur Thériault pour 6 minutes.
Mr. Thériault, 6 minutes. Thank you very much, Mr. Chairman. I'd like to thank all witnesses for their testimony today. I have a number of questions for Dr. Perrault. There is a refusal to take into consideration part of reality, and the federal government seems to want to wait until after the pandemic is over in order to work on some structural, recurring, substantial funding to solve part of this reality that they're not taking into consideration. On-COVID patients are treated on a one-time basis. This is really a really critical area that you work in, cardiology. What do you think of this constant waiting around? In fact, we're at the 6th wave, and already at the first wave, it was clear that the system was too fragile and that the repercussions over the long term would be extensive. Thank you for your question. I think your analysis is correct. The pandemic simply made existing problems obvious, like my colleague from the Royal College mentioned. In cardiology and cardiothoracic surgery, one thing we noticed at the beginning of the pandemic is that patients did not tend to go get health care because they did not want to be in the hospitals, which led to a number of new complications, but it also meant it shed light on the fact that some of the problems that could have been solved earlier on urgently were actually not addressed because of a lack of access to hospital resources. It was a completely normal, logical response from patients that they would be afraid to get COVID in the hospital, and that has had a number of consequences. One of the consequences is that patients show up in a deteriorated state. We're in the 21st century. We have a treatment. We have everything we need to treat the patient, but we can't get them in. So that means that it has an effect on their recovery. Another aspect is that if you wait too long, the delay that you've taken all this time wasted over this period means that the patients suffer. And I speak for my team. Of course, this is in cardiology, but in oncology, we know that it's a severe problem. Any delay means more advanced presentation. I would say the emergency of the issue was already there before the pandemic, but now it's really crucial to adjust the levels here of funding, transfers. It's important to make sure that this rebuilding and this recovery of activities has to happen. We simply cannot take this for another few years. And one other comment I'd like to make, actually on the basis of what I heard from some of my other colleagues who spoke, planning is critical to all teams, healthcare teams. We realize that in some provinces like mine, the number of surgery residents has decreased over the last 10 years, and this will mean if you have a surgical pathology, you're not as likely to get treated. So workforce planning can be engaged in, like my colleague from the Royal College said. It's really critical for the future, not only for doctors, surgeons, but for all healthcare providers and professionals. We have a critical shortage in some areas that have lasted for over 20 years, and that has to be addressed. These are 2 decades worth of problems that have been raised, and yet nothing's been done, nothing appropriate has been done. So the predictability that provinces in Quebec need in order to make their networks more robust, and especially in really critical areas like yours, this is an issue. Yeah, our area certainly, but also if I look at the number of speech pathologists in Canada, it's just a ridiculous number compared to what's going on in the U.S. If we would plan, if we could set out benchmarks, if we knew what the needs were, if we said, okay, we need X speech pathologists per, 1,000 Canadians, if we had some of this predictability, we could reduce the gap between what we have today and what would be ideal. Your general practitioners today and your specialists, your Federation of Specialists, agree that it's important to discuss funding of healthcare in a transparent way, in a summit on the funding of healthcare, on healthcare funding. I would imagine you would agree with these colleagues that are involved in this kind of an exercise. You probably want to take part in order to maximize and really make best use of financial resources. You know what your priorities are because you're out there in the field working, correct? Yes, I'd be for that. This is a critical exercise we all have to take part in because short-term solutions, and I'm not trying to lambaste anyone, but we've done it in our surgical profession, cardiac surgery. We've brought in doctors from abroad. These are reactive solutions that are temporary, but we need some substantive solutions, planning over the long term. Not a 4-5 year period, but 20 years. Training a surgeon takes 10 years. If you make a decision in 5 years, there will be a serious shortage in this specialized field. So a massive effort needs to be made to revise this funding issue and also to plan.
Next, Mr. Davies, please, for 6 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses for being here. To Ms. Wilson, please, of the Speech Language and Audiology Canada. What I'm wondering is the percentage of speech language pathologists who are women.
Oh, it's very, very high. It's probably 85%.
And what about audiologists? Similar?
Yeah, no, it's a little bit less. It's more male dominated in the audiology sector, probably half and half.
Okay. Now, the federal government's Canadian Occupational Projection System has estimated that over the period 2019 to 2028, the number of job openings for audiologists and speech language pathologists are expected to total 3,800, while the number of job seekers is expected to total 2,800. You've already spoken to the rather shocking discrepancy between SLPs in Canada and the US. I'm just wondering if you could explain to us what are the primary reasons for the shortages of SLPs in Canada?
I may ask my learned colleague, Dr. Ravachu, to speak to this just from her standpoint.
Of course.
And I can expand if needed.
The first issue, I think, is going to be the number of schools and the number of seats in Canada for training speech language pathologists. The number of audiologists is actually equivalent in the United States and in Canada. I'm not going to speak to whether it's enough, but it's equivalent. But for speech language pathologists, there just aren't enough being trained. So we're training, there's 12 schools and we're training 450 students per year. And that number has actually doubled in the past 6 years approximately. So we've been increasing the numbers of students that are being trained, and it's clearly not fast enough to double the number of speech pathologists in the country. And the needs have been increasing because of the aging of the population. So initially, speech pathology was very carefully directed at children. And now we have, with the aging of the population and the increase in the numbers of people with swallowing disorders, for example, the people in long-term care homes and post-stroke survivors and so on, there's just huge needs in the aging population. So the needs have expanded, and the capacity to train speech language pathologists has not expanded fast enough.
Ballpark, how many people apply to get into SLP programs every year? You mentioned we graduate around 400 and some a year. How many apply to get in?
Right. Well, there's a weird thing with that because the numbers that apply are actually going down because it's so hard to get in, and people are like, there's all these other healthcare professions where there's huge needs and everyone's competing for the same pie. However, that being said, like, for example, I'm at McGill and we have at least 200 applicants, sometimes 250, 275 applicants a year, and we accept 30 students. So the number of applicants per the number of students that are accepted, it's many, many, many. The requirements to get in are very, very tight. The students in our program, their grade point averages are very, very close to 4.0. So there is capacity to expand the number of students that we take into our programs.
Now, this is a bit of a, I think, no kidding question, but I wonder if you could just expand a little bit on the impact of early intervention for children, particularly on health outcomes, but just as importantly on downstream costs.
Well, I should have looked up that number because that there's actually very good data on that. But the main thing has to do with literacy. So what's often not recognized is that the prevention of literacy delay in school, the time to prevent that is in the preschool area. So the predictors of not learning to read are deficits in language skills and speech perception skills and speech production skills and what's called emergent literacy. And all that is happening between the ages of 3 and 5. So if a child starts school and their speech and language skills are not within normal limits at that point, at age 5, age 6, then there's a heightened risk of a whole bunch of bad outcomes, being bullied at school, social emotional problems, conduct disorders, ADHD, anxiety disorders in girls skyrocket, and not learning to read. So about 60% probability the child will have reading disability in grade 3. Then your chance of school failure increases. The probability that for boys, not girls, but boys, of coming into contact with the justice system increases, and so on. So the early intervention is absolutely, absolutely essential. And we are really falling down on that.
Thank you very
I have
much,
about
Dr.
15
Revishu. And
Apparently I don't.
okay, 15 seconds. Go ahead. You think you get a
Just
question
quick.
and answer in 15 seconds? Go ahead.
I'll do my best. We hear a lot from other professionals about burnout and people leaving the profession. Are we experiencing that in the SLP/audiology world?
There aren't studies on it, but we are women. I think it's actually higher than 85% now. And what people are doing is leaving the publicly funded health and going into private practice, reducing their caseload size, and because there's a big need in private practice. And quite frankly, I did that before I became a professor. It's just like, I just don't need this. And so you would rather to have a job where you feel like you're making a difference to your patients because of the rationing of care in the public system.
Thank you.
Thank you, Mr. Chair.
Thank you, Mr. Davies, Dr. Revishu. Next, we're going to go back to Dr. Ellis, please, for 5 minutes.
Thank you, Mr. Chair, and through you, sir, if I might, I'll kind of preface this. Now, I don't need the roadmap, but I've heard the College of Family Physicians and the Royal College both have a roadmap. I'll call it a roadmap to recovery for the healthcare system, and I guess I'll start with you, Dr. Lemire. Is that true? I guess that's the question, and is it something you would share with this committee?
I suspect that the roadmap that you're referring to is the rural roadmap. Dr. Bouchard, correct me. I'm not aware that we have another roadmap kicking around. Certainly, and the roadmap does speak to rural recruitment and retention of family physicians in rural and remote areas in Canada. And certainly, if you would like us to share this with you, we'll be pleased to do so.
Yes, thank you. And certainly we know that rural areas are perhaps more particularly affected in Canada for family physicians. And second question, Dr. Lemire, do we think we need to pay physicians differently? Certainly there's a lot of models out there now on how to remunerate physicians. You know, the world I came from was fee for service. And do you think it's time to make a more broad strokes with respect to how do we pay family doctors?
Thank you for the question. With the college is on record in suggesting that we need to take another look to broaden our horizons with regard to how we pay physicians. Many of the patients that we look after in family practice are people who have comorbidities, several medical conditions going on at the same time. Many have chronic conditions. The proportion of frail elderly in our practices is rising, and therefore looking after these people well, we feel requires a broadening of how we look at this. Some of the models which I described earlier have a model of payment that is what we refer to as a blended funding model, where a physician gets a fee, or the practice gets a fee per patient per year to look after them. And then there are some services within this that are provided where there's a fee for service component. So this is a model that we would suggest is the preferred model, and certainly might facilitate sort of a more comprehensive and proactive caring for patients.
Thank you, Dr.
I don't know.
Thank you. I just got a couple of minutes left here. And Dr. Lefebvre, is it fair for specialists similar things would apply?
Thank you. Yes, my husband's a family doctor, and I can tell you there's a lot more similarities than differences between specialists and family physicians when it comes to these issues. And I really do think the solution, as you've heard from many of my colleagues, is to work together, right? Better data means better planning, and we really need to plan and support in an integrated way, which reflects the way in which we deliver the care. We are already collaborating through the Canadian Medical Forum closely with Dr. Lemire and the College of Family Physicians, and looking at, for example, the role in remote realities, the integration of primary care specialists with other specialists will be key, but as well with other providers. And what we hear from our fellows right now is on how they would love the resources to better support the system as a whole. We've referred to the administrative staff, the nursing, the patient at the center, and the team that we need to support it. And we really don't have that data.
And we got about 30 seconds left. Dr. Lefebvre, is it fair to say that my pie in the sky idea of a pan-Canadian electronic medical record would really be essential to, I mean, it would speed up care in my mind and make care a lot better and more comprehensive. Is that fair?
Having a system where, again, patient at the center, and we all can talk to that same reality, does seem to be definitely an advantage. The implementation of this and making sure that the physicians who deliver the care and other healthcare workers have access to that, and the implications relating to privacy and so forth, are some of the challenges that stand in the way, I think.
Thank you, Dr. Lefebvre. Thank you, Dr. Ellis. Next, Mr. Van Couverden, please, for 5 minutes.
Thank you very much, Mr. Chair. I believe that I should start, like many of my other colleagues have, by declaring a bias or a conflict. My girlfriend is also a speech-language pathologist, and so my questions will probably focus there mostly today. Dr. Ravachu, Emily Wood says hi. She's my girlfriend, and you taught her at McGill, so she said you'd probably remember her.
I do indeed.
She's doing a PhD now at U of T, so she'll probably reach out to you at some point and discuss her research. But over the last couple of years, and actually because of the onset of the pandemic, she started a study on telehealth. So I was hoping to focus a little bit about speech-language pathology specifically, but it could expand to other modalities as well. Telehealth provides us with an opportunity to look at how, some of these challenges with respect to availability of SLPs and audiologists in remote northern communities could be applied. Obviously, there's other challenges around connectivity there. But could you just speak briefly about some of the potential outcomes for SLPs that could reach people that otherwise wouldn't have access to one?
Yes. So speech-language pathologists switched over to telehealth extremely fast. And the professional association, so SAC nationally, and the AUDRA in Quebec, and at the provincial level all across Canada, there were many different types of supports that were offered to speech-language pathologists to help them do that, to learn how to do it and to find out what kind of equipment that they needed and so on. And so it's been 2 years, and we actually have quite a lot of experience with it, and we're teaching our students how to use that model, and they're getting more and more of their clinical practice hours in telehealth. So we're quite excited about it. There are many issues that Dr. McGuire actually spoke to. So the first one is the integrity of the I'm sorry, I'm stupid about the words for this stuff, but the Wi-Fi that you have and those kind of connectivity issues. Because for speech language pathology, it's especially important. You have to have good quality sound, and sound delays and so on can be kind of devastating when you're doing speech therapy. So you need to have good quality connectivity. And the other thing that makes a difference for the equity of the services that the patient or the client has to have equipment as well. And not everybody has that equipment, or they might not have good enough equipment. So we have to provide those people with the equipment. And then the third thing is that the speech pathologist has to have skills, and not everybody is equally skilled. And then it has to work for the very many different kinds of things that speech language pathologists do, because we're treating different disorders in different ways. And right now it's not clear that it works for everything. So in our school, we have speech pathologists and students that are providing that service for different kinds of disorders, and it seems to be working quite well for certain kinds of things. But we did a study in my lab, for example, for a very severe kind of speech disorder called apraxia of speech, and it didn't work. It wasn't good. So it works well for some kinds of things, not well for other kinds of things. And I'm a little bit worried that what will happen is that people will decide to provide interventions that are suited to the modality rather than providing treatments that are suited to the problem that the patient has.
Thank you, doctor. Sorry, I just had I'm limited on time, and I have another little bit of a question. One of the things that I've learned from Emily is that undiagnosed hearing impairments often lead to really negative future health and societal outcomes for people, particularly young people, that was touched on earlier. I also represent one of the largest deaf populations in Milton because we have the largest deaf school in Milton. Could you just speak briefly about an opportunity that exists, by applying some of these assessments earlier in life, potentially through a new national universal early learning and childcare program, that we might be able to assess some of these challenges earlier in children, providing better outcomes later in life?
I'm very excited about the National Child Care Program. There's so many opportunities that are associated with national child care programs. In terms of hearing loss, though, the universal hearing screening programs across the country are the most important thing. So because a lot of hearing loss, babies are born with it. So I think that's really important. And then there are hearing losses that are associated with otitis media, very common in the Indigenous population, for example. So having screening in the preschools is very important. And then there's the opportunity to provide early interventions through those preschools to the children, to families, and so on. So I think it's a very important opportunity that that we should take advantage of. My daughter has autism, and she's 33 now, but when she was really young, we were receiving her services in the daycare for a while, and it was marvelous. They were very good. And then for some reason, the government of Alberta decided that wasn't a good thing to do, and they just withdrew the services, and it was quite devastating. So I really look forward to the possibilities.
Thank you, Doctor. I'll tell Emily you say hi.
Thank you, Mr. Van Couverden. Suite, Monsieur Thériault, pour 2 minutes et demie.
Merci. 2.5 minutes, Mr. Thériault. Thank you, Mr. Chairman. I have a question for the Canadian Pharmacists Association. Throughout the pandemic, there have been shortages of drugs that meant a burden on patients, but also on healthcare providers. Has the situation improved? Has Health Canada been vigilant enough, or is it being vigilant enough on supply? Are the right measures being taken to avoid this kind of a shortage?
Thank you for the question. You know, drug shortages are a part of the daily life of community pharmacists. The pandemic made it more stressful. It made the pressures more significant, and it ebbs and flows. I think the reality is that pharmacists and the government need to have conversations. We need to be involved in the planning. We need to be ahead of the game as much as possible, and we would welcome any opportunities to continue the dialogue to ensure that we set up our pharmacies with the resources, with the drugs, with the medications that they need to help the patients that they serve.
How can I put this? Is it a source of anxiety or stress for providers?
Absolutely. Just imagine what it's like to be the face that is delivering that message to your patient that you're not going to be able to continue with the therapy that you've been on because it's just not available. You know, it requires us to become creative problem solvers. We need to collaborate with our other healthcare providers. As you've seen here, there's huge opportunities for us to work interprofessionally to establish what the best plan is moving forward, whether or not we need to substitute, whether or not we need to modify medication based on availability. I think there's a lot there to discuss and unpack. And the bottom line is, yes, it is a huge source of stress and anxiety for our profession.
Merci, Mr. Thériault and Dr. Pace. Next, Mr. Davies, please, for 2.5 minutes.
Well, while we're outing ourselves, I am married to a speech language pathologist here in Vancouver, Cheryl Baum, who works at Children's Hospital, so I wanted to give her a shout out. She's on the craniofacial team. But it's caused me to have a lifelong deep respect for the work that SLPs and audiologists do, and I want to thank you for being here. I have two quick questions, one to the College of Family Physicians of Canada. At present, how many Canadians is it estimated lack access to a family doctor?
4.6 million.
Is that getting better or worse?
I guess the jury is out at the moment. If our concerns around upcoming retirements of family physicians prove to be true, we will have more Canadians who will be without a family doctor.
Okay, thank you. Dr. Lefebvre, it's notoriously difficult in this country for foreign trained doctors to practice in Canada. There's public jokes made about it, that the healthiest place to have a heart attack in the country is in a taxi cab. Why is this? And what can be done?
Great question, thank you. We, of course, want to have the best physicians possible to look after the population of Canada. And the processes that we require for both Canadians and physicians outside of Canada to join need to be equitable in a way that when you see a physician anywhere in this country, whatever the province, whether you're rural or in the city, you can trust that the standards are there. And there are processes to, of course, ensure that. There's a complexity when a physician comes from out of country linked to their background, their culture, the immigration, and so forth, which has to be respected. And I think at the same time, we as a population are mindful of the fact that it takes a lot of energy for a country to train a physician to become a physician, and we shouldn't be seen as people who make it too easy to actually grab from poorer nations to bring them into the country. So that fine line of absolutely, if you're going to be a physician in this country, I'd rather have you as a physician than a taxi driver. But let's do the best we can to train the number of physicians that we need in this country right here.
Thank you, Dr. Lefebvre and Mr. Davies. Next, Ms. Goodridge, please, for 5 minutes.
Thank you so much, and thank you to all the witnesses for spending some time with us here this afternoon. It's really been remarkable. The more witnesses we hear, the more commonalities we seem to hear all across a variety of different spaces and places. And Dr. McGuire, I'm going to start with you. You really hit something that I think rings true to me. And so I was just wondering if you could expand a little bit further on how you would see a federal locum program working, and if you could design it, what would your dream program look like?
Thanks very much for that question. The reason why I speak to the importance of locums across the country is so that rural doctors know they can get a break when they need it. I know that they're developing national standards around licensure and encouraging the provinces to work together for licensure already. So I think that's great work. I think it would be great if that would continue. I would love to see it happen so that there would be a registry, so that when we know in advance that a doctor is going to need time away, we could contact that registry, who would then put us in touch with interested doctors. It's a great way for doctors to help out colleagues across the country, to see how different systems work across the country. I think the more we know about the practice in different parts of the country, the better our healthcare system gets overall. So I think that's what I would see. I would see it as a standardized licensure process, and then have something where there'd be a degree of reciprocity, so that the provinces would say, okay, this doctor is already licensed in another jurisdiction in Canada, whose standards are obviously very similar to our own. And if we can extend temporary licensure quickly to those doctors to allow them to come and help out, that's some of the components that I would see as being part of that.
Fantastic. I know it's something that I hear regularly, concerns, whether it be in Cold Lake, in Lac La Biche, or Fort McMurray, people with concerns over lack of care. And my understanding is we, grosso modo, have the right number of doctors. They're just not in the right spaces across the country. Is that accurate?
Speaking in Nova Scotia for psychiatry, we certainly could use more distribution of psychiatrists from the city out to the more rural areas. But as a general trend, I think there might be some truth to that, actually.
Excellent. Dr. Lefebvre, what about, I'm just curious to hear your thoughts on having a federal locum program, and just wondering if you could expand upon that a little bit.
Thanks. Again, I'll be a bit of a broken record on the fact that we don't have data, right? So I in your previous question, do we have enough doctors? I don't know. And do we have the right kind of doctors? And could we actually use that data set to inform our medical students to help them choose which profession they go in? There's been a trend in my own career where when I graduated from my residency, every one of my colleagues wanted to have an office and a position and had in mind that they would have this for life. That's no longer the truth. We now have residents who see themselves graduating with the flexibility to have locums and not have the burden of an administrative office and so forth. So I think it goes both ways, looking at what our graduating physicians are looking for to meet the needs of the populations, and starting with what does the population need. Absolutely, we've heard.
So sorry, I've got about a minute left. So super quickly, you touched on the next point I was going to get to. Doctors that are my generation, what I hear is they want work-life balance. They want flexibility. And I'm just wondering, are there any studies on that? And if so, if you could table that with the House, or studies on any of that, that would be spectacular if you could table it with us and the committee.
There is more data coming out on and I will actually put forward that this generation of physicians is actually teaching us to be wiser about things. They're looking at the rate of burnout we're seeing and saying, we don't want to be in that position, help us not be there. So absolutely, the work-life blending that physicians hope to have is a reality and should be an important question as we look at not only the number of physicians we have, but what those physicians are willing to do. And the physician who puts in 150 hours a week, the rural person who ends up having to be on call 1 day in 2, that's unsustainable. So when we look at issues like rural and remote, work-life balance is an important consideration in that equation.
Thank you, Dr. Lefebvre. Ms. Goodrich. Next, Dr. Pawlowski, please, for 5 minutes.
Thank you. So we're all here trying to address the problem of shortages in the workforce in healthcare. And certainly Dr. McGuire has talked about the possibility of using more foreign graduates. And I guess I'm the old man here of the group of doctors. I graduated 36 years ago. And you know what? Absolutely nothing has changed in 36 years with respect to licensing foreign graduates. They've been around, and a number of us have worked in areas. I've worked most of my life in underserviced areas. And there have always been a lot of foreign doctors in Canada that we could, should we wish to, provide them a pathway to upgrade their skills if necessary so they could practice in Canada. But why hasn't it happened in 36 years? And I'm looking across at a couple of other doctors here are in a similar situation. They too have worked in underserviced areas. I'm frustrated with this. And we talked about differences and Dr. Lefebvre, I think, talked about bringing people to the right level. But she's an obstetrician. I've done cesarean sections myself in developing countries, and I know there's a lot of foreign grads who can do better cesarean sections than Canadian doctors. So if necessary, we can train people, get them up to the required level in order to practice in Canada. So what has been the problem? I would suggest, and I want to ask a whole bunch of you, I would suggest there are a number of possible problems. One, protectionism. There's doctor in organizations like CMA, OMA, they represent all doctors. And yes, doctors in rural areas may want to attract more foreign graduates, but I've also done a little bit of work, not much, in big centers like Toronto, and you know what? You don't have enough patients in those places. So you're trying to get people in. So if you're a doctor in a big center, you may not want to license a lot of foreign doctors because that's more competition for you and the possibility you will earn less income. So one, I'm suggesting maybe there's some protectionism amongst the medical profession in not making it easier for foreign doctors to get work here. The second, the possibility that the provinces don't want to have more billing numbers because that means higher costs. The third is the problem of colleges and the real kind of problem in that they don't meet the same standards as us. And fourth is the problem with us and the federal government in immigration. But Dr. Maguire, maybe I can start with you, and then I'll pass it on to the College of Family, the Canadian College of Family Practitioners, and the Royal College. And I note that neither of those two bodies mentioned increasing use of foreign doctors. So Dr. Maguire, maybe we can start with you.
Doctor, just if I could just ask you to clarify the specific question.
What's the problem? Is it a problem of, do you think there's protectionism in the medical community that is hindering us licensing more doctors, or is the problem that the provinces aren't willing to issue more billing numbers, or what's the problem in not licensing more foreign doctors?
That's a good question. I think that, Dr. Lefebvre spoke to some of the differences in where doctors are trained and how they're trained. When we bring a new doctor to Canada, we also need to consider their ability to transfer those skills to a different culture. And so I think there's probably a fair bit of work that could be done to look at some of those barriers and try to remove them. I think would be a good idea. By the way, doctor, I just want to mention that before I did psychiatry, I did my family medicine North residency training in Thunder Bay.
So can I ask the same question then of the College of Family Practitioners of Canada and also Dr. Lefebvre and the Royal Colleges? What's the barrier for foreign doctors to be able to practice in Canada? Is there medical protectionism involved in not licensing more foreign grads?
So I don't know. Brady, did you want to speak to this?
If you wouldn't mind, Dr. Lemire.
Sure.
So you had multiple parts to that question, of course. I think certainly the IMG assessment programs that I'm familiar with are provincial, so there's certainly provincial responsibility there. One obvious structural barrier is that after a certain number of years in Canada of not practicing, IMGs are, to my understanding, generally not eligible to enter retraining and assessment programs, so that might be a barrier. I would say to your second point around protectionism, I'm willing to acknowledge that may be happening. We are so desperately short of family physicians where I practice and everywhere that I've heard from colleagues that I can't see anything but welcoming arms to have additional colleagues, foreign trained or not, working in our communities. I would be remiss if I didn't reiterate Dr. Lefebvre's point as well about the ethics of making it perhaps too easy to immigrate and practice in Canada. That we are there's a lot of resources that go into training a physician, and that perhaps bringing them over from overseas that have put the effort into training them. There's some ethical issues there.
Thank you, Dr. Bouchard and Dr. Pawlowski. Dr. Lefebvre, we're not going to get to you on this. We're well past time. You are more than welcome and encouraged if you're so motivated to drop us a note to augment any of your testimony, including an answer to this question. Next, we have Mr. Barrett, please, for 5 minutes.
Well, thanks very much, Chair. Thanks to all the witnesses for being here today. So I wanted to follow up. I believe it was Dr. Lemire who had said that the number of Canadians that don't have a family doc, did you say it was 4.7 million?
Those are the data that we have, yes.
Okay, so how many doctors would it take to fill that gap?
So it depends on how you calculate it, but we would say that a family physician should be the most responsible provider for about 1,000 to 1,200 people. That is, if this person is doing this solely as their scope of work. Many family physicians also will have certain clinical areas where they spend more of their clinical time. So if that happens, then obviously the number of people that family doctor can look after would be less. It would be probably between 500 and 1,000.
Right. And so building on that, I want to ask about the level of care. So based on the calculations that are done on how many doctors we need, in the context of a strained healthcare system where we have doctors who specialize in areas that they like or are most proficient at, and they also then lend themselves in areas where they're needed. So they do extra rotations in hospitals, or in the context of COVID, they're working at COVID centers. Are the doctors providing the level of care that Canadians need and that doctors want to be able to provide to Canadians? So, we hear an awful lot about Canadians who are frustrated that they don't get an annual physical, or that they can only have one issue per visit. Hear that all the time, that the docs only have time to deal with one issue per visit. Delayed routine screenings, delayed care or canceled care appointments. This stuff happening before COVID, which has been exacerbated during COVID. And this list is not it seems to be that these are all symptoms of doctors who have too many patients and are doing too many things. So is the number of doctors we need really more than just to serve 4.7 million? Because do we have an awful lot of Canadians right now who are on the list at a physician's office, but that doctor can't provide the level of care that they would like to provide, or that individual would like to receive?
We need more family doctors, not only family doctors to look after the 4.6 million who do not have one, but we need more family doctors in this country. I think to respond to the rest of your question, I'll ask Dr. Bouchard to do so, because he is on the ground and he is providing care in a particular clinical area, mainly because that care is needed in his community. Dr. Bouchard?
Thank you, Dr. Lemire. Certainly there was significant adaptations throughout the pandemic from physicians stepping into areas where they don't traditionally practice or haven't traditionally practiced, and have done their best to provide a high quality of care to get Canadians, but that's certainly leading to burnout as well. You mentioned the idea of being overextended. Certainly, I mean, this is a complex issue. One of the issues that was touched on previously is around models of remuneration. So particularly in some of our urban areas across the country, inflation and overhead and staff salaries, administrative overhead for a practice is astronomically increased, particularly post-pandemic. And part of that is just to try to make a living in a fee-for-service practice, for example, where what you can bill and what you can earn into your practice is a set rate that is not changing. Physicians are trying to do their best, and sometimes that may lend itself to limiting to one issue, although we certainly don't endorse that approach. The other part of that is just the complexity of Canadians. Canadians are aging. They have more medical conditions. They have complex care. There's more therapeutic options available to them. They're waiting longer for specialist consultation. They're waiting longer for surgeries. And all of that is certainly contributing to burnout, but it's also contributing to, how many patients can I effectively manage in my practice? And certainly I hear from colleagues across the country who have practices, they may have 1,000 or 1,200 patients that they've had for their career, and they're not going to let those patients go. They're not going to fire patients because there is no other provider. But they do feel overextended for those reasons that I mentioned and many other reasons. Thank you.
Thank you, Dr. Bouchard and Mr. Barrett. Next, Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair, and thank you all the witnesses for your testimony. We all heard that, Dr. Lemire, you said 4.6 million people do not have access to family physician, and Dr. Bouchard, you said we have a shortage of family physician, and you hit the nail, Dr. Bouchard. Aging population, they need complex care. So that means we need more doctor. And we heard before that the Canadians who attend medical school here have a difficulty finding residencies. Sometimes they have to go to US. What can be done to increase the number of opportunities to those students?
Thank you. I think, the obvious answer is that we need to increase medical school enrollment and residency places across the country. And we have to make the practice environment enticing to learners. So we're only going to entice medical students and residents to train in family practice, where they can see that their preceptors, their teachers are thriving and enjoying their practice environment. I trained as what we call a Canadian studying abroad. So I went to Australia for medical school and then came back to practice. I'm from Saskatchewan. I practice in Saskatchewan. For that reason, there is not enough spots in Canada. And I was lucky to be able to come back. I was one applicant. There was 4 spots for my residency site, and there were 700 applicants. So it is not at all easy. Thank you.
So Dr. Lafay, you want to add on that?
I agree. We have the same reality when medical students choose to be residents. They have a choice of College of Family Physicians and then a variety of specialties at the Royal College, and increasing access absolutely is part of the solution. Of course, nothing is easy in that, because as you increase access, you have to increase the number of teachers, and the teachers are also people who are somewhat smothered right now in a system that is overburdened. So again, having those multi-professional conversations of how we address the issue. And I think as much as we need doctors, we also need a system that respects that we support doctors to be doctors. And some of the problem we see right now is we have physicians who will tell us 30% of their day is spent on administrative tasks. If we could lighten up that load, our doctors, one, would have a better quality of practice, but we would be able to expand the reach.
And Dr. Lafay, you have spoken several times the need for better data collection to inform decision making. As it stands now, which organizations are collecting useful data, and what areas do we need better data? You also said that centralized data, there's some concern maybe for the privacy, but what specific recommendation do you have on improving data?
We have limited access to data as a whole for the entire system. There is an opportunity, I think, through the Canadian Medical Association to look at creating a national data set that could go beyond only physicians, but actually include our colleagues as well. The data in terms of physicians that we use often is CIHI, the Canadian Institute for Health Information. That data was not actually, those data sets are private to this through the Scots Registry and really not created to be able to collect the right data about our physicians. And to echo Dr. Lemire, part of the problem in those data sets that were not created for the right reason is we don't really have, as part of the data, what it is that person is doing in their practice. A dermatologist working in a cosmetic clinic is very different than a dermatologist who works in ICU in a hospital, for example, and there's varieties of complexities that way. I do think most of our organizations would be willing and able to contribute to a federally funded data set.
Thank you. And if we're talking about pan-Canadian, which other healthcare professionals, if any, would a pan-Canadian license model be useful? Dr. Lemire, you want to add on that?
Just want to be sure I understand the question. You're asking me which professionals or providers besides physicians would benefit from a national licensure enablement?
Yes.
I would probably suggest nursing for sure.
Can I interject?
Pharmacy, pharmacy. I mean, I think the list could be actually quite long of professions that would lend themselves well to national licensure and would therefore enable, facilitate those who provide care, and that's pharmacists, nursing, physicians in some rural, remote communities to get a break. To be able to take a vacation. So I think that goes beyond physicians.
Can I add to that?
Very briefly, please.
Yeah. So, a national licensure would also promote mobility between provinces. We want to have a national approach to making sure we understand the needs. And that right now, we don't have any data to support the demands. We know what the supply is, but we really need to look at what the demands are and then collectively work at mobilizing our healthcare workforce to meet those needs and removing any barriers.
Thank you, Dr. Pace. Thank you, Ms. Sidou. Monsieur Thériault pour 2 minutes et demie.
Mr. Thériault, 2.5 minutes. Yes, thank you. I'll start with the Canadian Pharmacists Association. Quebec, for the last little while, with respect to Paxlovid, pharmacists apparently can prescribe it. I thought after a diagnosis, pharmacists were actually more competent than doctors, and to some, no disrespect towards my colleagues here, but for that type of prescription or to deliver these drugs. What's your approach? This capacity to prescribe. Perhaps you could address that Paxlovid as well.
Yeah, absolutely. Paxlovid is a really great example, and kudos to Quebec for enabling pharmacists to participate in increasing the access to patients and getting it into the hands of high-risk individuals and keeping them out of hospitals. I think it's really about optimizing our education as medication experts. It's not necessarily about, it's a collaborative approach. And when it comes to the pandemic, we've seen how pharmacists have stepped up. We've been involved in testing. We've been involved in screening, in administering vaccines. So it's very natural that if you're already going to a pharmacist to provide you with, the pandemic services that we've had throughout the pandemic, prescribing for Paxlovid is a natural fit. And it's also really important because of the short duration for efficacy. We know that there's a short window, 5 days. So, going to different healthcare settings to navigate this is very complicated for patients. And so making sure that we're removing those barriers, giving access is so important. And pharmacists are well versed in drug interactions. They have a full patient history. It would be lovely if they had access to this medical records, but they can work in collaboration with family physicians and other healthcare providers to make sure that the monitoring and follow-up takes place. But it's a very natural fit for pharmacists, and it makes sense because that relationship is already established with the patients that they serve.
Donc, c'est une pratique.
So that's a practice that you would like to see happen outside of Quebec, if I understand you correctly?
Absolutely. This is again about making sure that we are giving Canadians access to the medications and the services that they need, regardless of the postal code that they live in. You know, we need to see this type of progressive, creative, and meet the patients where they're at approach to healthcare across the country. So, kudos to Quebec for demonstrating how this model can work.
Thank you, Dr. Pace and Mr. Theriault. Next, Mr. Davies, please, for 2.5 minutes.
Thank you, Dr. Lefebvre. I get my teeth cleaned every 6 months by this wonderful person who's a Bulgarian-trained pediatrician who came to Canada, actually did all the requirements she had to for her schooling, but couldn't get a residency. And I think this was just touched on. Would I be correct in speculating that Canada has a real bottleneck? We have too few residencies. Is that part of the problem as well for all those that may be seeking to qualify to practice medicine in Canada?
Thank you. Obviously, I'm not in a position to comment on your individual,
right.
that individual circumstance.
Nor on the state of my teeth.
Or which I'm sure are great. It's funny how life diverts us sometimes. We have a lot of specialties in Canada, and at the Royal College, we continuously talk to members on what additional competence they need and what subspecialties we build. Again, what's missing is that data capture of where are we missing individuals and how do we release that? Do we have a little too many here and a little not enough over there? And that has not been the purview of the Royal College. The access to specialty exists. How it gets managed in the field is something that we definitely are keen to collaborate on.
Thank you. My last question to Ms. Wilson. Last word to you. What would you recommend to the federal government to help address the shortage of speech-language pathologists and audiologists in Canada?
Thank you for the question. I think what we need to do is consider creating more spots for speech-language pathologists in schools. I think we need to consider more funding for jobs. Speech-language pathologists are subject to funding cuts and have been throughout this pandemic. So the government needs to be accountable for healthcare transfers that go to provinces to support the vital funding that we need to support the jobs that are being cut. And I think lastly, we need to ensure that we have people coming into the profession by providing the right supports. Right now, speech-language pathologists in particular are not the most well compensated. So with move to private practice, because there's loss of jobs in the public sector, the government could look at supporting the right mixture for employment for speech-language pathologists. We are losing people every day based on caseload, burnout, poor wages. So that really is a concern. And once people go into private practice, they are also faced with the same types of issues because there's a lack of funding for people in the community for the services that they need. So that also falls onto the other side of things in terms of how services are funded to the people that need them, the public like you and I and our children. How do we manage insurance coverage? How do we manage the right support so people can manage access to services?
Thank
so
you, Ms.
Wilson. A number of things.
Thank you. Thank you, Mr. Davies. Next, Ms. Goodridge, please, for 5 minutes.
All right. Thank you so much. This question will be for Dr. Bouchard. You touched briefly on how inflation really impacts doctors in a fee-for-service space. I'm wondering if current record-breaking inflation that's currently at 5.7, if you guys are feeling an impact on that in practice in your area.
Thank you for the question. Absolutely. I mentioned probably, although it's not my personal experience, our urban areas, so Vancouver and the Greater Toronto area certainly are feeling it the most. but we're feeling it across the board. And I want to emphasize again, in that fee-for-service setting where family physicians are running a business, they need to pay for medical office administrator, clinical nurse, salaries within their clinic. They need to pay overhead. They need to pay for medical supplies. They need to pay for utilities. Absolutely, they're feeling the hurt. And that's part of the uniqueness as well. Other businesses can increase prices. We're certainly not advocating for that for family physicians. We strongly believe in a publicly funded Medicare system, but it does limit how you can make a living.
So effectively, you're saying that this rising inflation is making it more difficult for doctors to just do their job.
Absolutely, and that's why we see physicians moving out of practice. I mean, that trend was pre-pandemic as well, moving out of comprehensive office practice and moving into areas such as, hospitalist care, obstetric care, emergency medicine, areas where they do not need to carry the burden of overhead and staff salaries. And we need to reverse that trend.
Well, wonderful. I hope my colleagues opposite have heard the fact that just continuously printing money has some consequences on, as we're currently hearing, public health. But I guess one other question I have for you, highlighting the fact that you had to study abroad, do you think that there is a space for universities across the country to have more space for students from rural communities to be able to get into med schools?
Yes, absolutely. And that's part of the rural roadmap that Dr. Lemire mentioned before, that we've collaborated on with the Society of Rural Physicians of Canada. The key to recruiting rural physicians to practice rurally, whether that's family physicians or specialists, is recruiting medical students from those communities. So people who have ties to a community already are much more likely to go back to a community and practice, and more likely to stay there. So I think it's a clear, smart strategy going forward.
Fantastic. So do you have any other suggestions on how we could recruit and have more rural physicians?
Certainly the advent of virtual care has made it easier for patients to access specialist care across kind of geographic barriers. That's certainly a barrier for rural physicians. I practice rurally. Burnout, that's an additional contributor to burnout for rural physicians, is that moral injury of trying to get patients access to care that they may be able to access if in a more urban setting. So we need rural health equity. And certainly what's been mentioned by everybody else here, we need data nationally around what is the distribution of physicians, where may we be over-resourced, are we mal-distributed, or do we just not have enough, and who's doing what practice where, because a family physician is not a family physician. A Royal College specialist is not a Royal College specialist.
Wonderful. And then I guess, Dr. McGuire, real quick question. Are there any jurisdictions in Canada that are doing better that we could perhaps look to?
Yeah, I mean, actually, there are a couple of schools in Canada. Memorial University is actually doing a lot of work in the area of recruiting, rural students. Also, areas of Ontario in terms of some of their, more rural and remote training programs. Those are all really worth looking at, and there's some good success happening there that could be certainly, copied in other parts of the country.
Thank you, Ms. Goodridge and Dr. McGuire. The last round of questions are going to come from Mr. Johari for 5 minutes.
Thank you, Mr. Chair, and thank you to all our witnesses. Specifically, thank you to my colleague, MP Don Davis, for opening the opportunity for me to acknowledge all the oral health workers, especially the restorative hygienist. I'd like to acknowledge my wife. I looked at all my colleagues. I didn't want to go home on Thursday night and have not acknowledged my wife. She is amazing. I attest to that, as well as all the patients who she's been working for the past 22 years. So here you go, Humera, you're amazing. I also I like to go to Dr. Pace. I have a very good friend of mine, Dr. Akil Durrani, who is a pharmacist, who has a number of pharmacy across GTA, and one of them is in my riding. And we often engage in a very deep conversation around various skills that the pharmacists can bring to the table as it comes to oral health. Talks about the utilization of other capabilities as it relates to the pharmacists. We talk about national licensure, which we talked about today. Opportunities for actually forming a patient-centric care where all the healthcare providers come together and provide an integrated care, and also partnership with various levels of government, as well as prescribing capabilities. Now, in your opening remarks, you talked about lack of consistency in the scope of services and fragmented funding. Can you please expand on this and how, especially with the lens of virtual care, can you expand on this lack of consistency and the implication of us one day being able to move into the virtual care?
Thank you for the question. The lack of consistency is a huge area of frustration for the profession because depending on where you're practicing, you're able to do things, and the funding and support in order to be able to offer these services that we are capable of doing to our patients is limited. And so there's a huge opportunity for us to rethink what healthcare looks like. When you enter the doors of a pharmacy, you're not just entering the doors to see your pharmacist, you're entering the doors to Canada's healthcare system. And I think there needs to be this shift to incorporating pharmacists into the greater healthcare system and rethinking how we can utilize our skills and our knowledge in collaboration with the other healthcare providers and the other systems in place so that we're not only being efficient, but we're being effective. We don't know right now, there's no way of showing what those pharmacist interventions the impact that they have on prevention of hospital room visits. We want to be able to triage patients and make sure that we catch their conditions, make sure their healthcare conditions are managed early on, and it's not later on when the implications, and we've heard it earlier, the delay to treatment, even to identifying therapy, has severe consequences for the patient and for the healthcare system. And so leveraging pharmacists is a really smart thing to do. And it's what we want to do. We want to provide care. But I will say that the system needs to be supportive of that. And that includes funding, that includes reduced administrative burden. There's so many barriers that are system constraints that prevent us from being able to deliver the care that we want to and that we're capable of doing.
Thank you. You talked about the barriers that they're system specific. Again, I'm going to go back to virtual care. Can you highlight some of the opportunity that exists there for us to be able to, move even faster if needed and when it's needed into virtual care?
Yes, thank you for the question. Virtual care it's double-edged, right? It's wonderful because it gives access to patients in the comfort of their home. That being said, not everybody has access to technology. And so in rural parts of Northern Ontario, I've spoken to a pharmacist who said that he had to set up a kiosk in his pharmacy to help his patients download their QR code to show that they were, immunized. So there is a whole group of patients in a demographic that virtual care may not be the right method, but it's a multimodal system. And in some cases, the access to virtual care would be a phenomenal asset to individuals, especially if you wanted to do a medication review, if you wanted to consult on a drug related question or query. I think there's a lot of opportunity there. Technology can be an enabler, but it is not the solution for everybody. And being able, knowing that most people live within 95% of the population lives within 5 kilometers of a pharmacy, you have access points already in place. So let's rethink how we leverage and utilize our existing workforce so that we can care for Canadians the way we know how and want to.
Thank you very much, Dr. Pace and Mr. Johari, and thank you to all of our witnesses for being with us today. This has been a fascinating and informative discussion. Thank you for the work that you do on behalf of patients and on behalf of your colleagues in your respective professions, and for your articulate presentations here today. We are extremely grateful to you. It will aid us greatly as we put together a report for Parliament. So with that, is it the will of the committee to adjourn the meeting? It is. We're adjourned. Thanks, everyone. Have a good evening.
Thank you very much.